All right. Thank you so much, Tony and Vivian, for all those great examples and making it very real. I really loved that session. And now I am very excited to welcome our first full panel to the stage. This next conversation on the future of AI in healthcare will be moderated by Dr. Ainsley MacLean, who is Chief Medical Information Officer and Chief AI Officer for the Mid-Atlantic Permanente Medical Group. Dr. MacLean oversees a team of software engineers, physician informaticists, and clinical analysts in the design and implementation of technology, AI, and telehealth enhancements. She is founder and a co-executive sponsor of the Permanente Medicine Artificial Intelligence Center of Excellence, and she's certified by and on the board for the American Board of AI and Medicine. She is also an associate medical director overseeing radiology teams and in an ultrasound program that spans 20 different specialties. Dr. MacLean, thank you so much for joining us, and I will turn it over to you.
Yeah. Thank you so much. Thank you. Let's keep going. Well, good morning, everyone. It's so wonderful to be here. I really want to thank the KP Institute for Policy for putting on this conversation. At this moment in time, we're at such a point of excitement looking forward, and conversations like this are critical in ensuring that everything is done well for our patients. So thank you so much. So I'm going to introduce our first panelists, and I'll let you know a little bit about how this is going to work. So each of our panelists, who are amazing, are going to actually give some brief comments and an overview of their opinions on what the future of AI in healthcare holds. And then we'll sit up here together and we'll have a little conversation, and then we'll have an opportunity for some of you to ask questions as well. So I hope it's really engaging. And again, we're going to be now moving from the present to the future. So our first panelist is Dr. Junaid Bajwa. He's the Chief Medical Scientist for Microsoft Research, and he's going to be talking about an exercise of our imagination. Our next panelist is Dr. Julia Adler-Milstein. She's the Chief of the Division of Clinical Informatics and Digital Transformation and Director for the Center for Clinical Informatics and Improvement Research at UCSF. And she's going to be talking about AI at UCSF Health. And our final panelist is Dr. Judy Gichoya, who is an Associate Professor of Radiology and Informatics and an Interventional Radiologist at Emory. She's going to be talking about the future of AI in healthcare, capacity building for an AI-enabled future. So please join me in welcoming our panelists to the stage.
I might stand here, if that's okay. I'm tall enough as it is. So, good morning, everybody. My name's Junaid Bajwa. I'm the Chief Medical Scientist at Microsoft Research. I'm a practicing physician in the UK's National Health Service, and I'm delighted to be here. My sincere thanks to the KP team for the kind introduction. Feel free to connect with me on your social poison of choice, if that could be helpful. Very happy to engage in conversations. Before I start, we've spoken a little bit about these new tools. And without making any judgments, how many of you have used any of these tools in the last year? Just a show of hands. Who hasn't ever used any of these? Okay, so a fair few. How many of you have used them for work? Okay, interesting. Okay, fine. That's a nice baseline for me to start with. So one of my challenges was to think about actually how do we just ground everybody in what we potentially will begin to discuss a little bit about today. So I've spent most of the last 20-odd years across the payer, provider, regulatory, life sciences, and now big tech side of healthcare. So one might argue that I just never stopped doing rotations. And the other argument is I just wanted to make my mum really proud and make sure that I do lots of different things with my life. So I sit on the board of the MHRA, which is the UK's equivalent of the FDA. I'm on the board of a large academic medical centre in the UK known as UCLH. And the thing that really drives me is impact at scale and really thinking through not just health equity, but population health, reducing the cost of care of healthcare, but also improving the experience of care for those on the receiving side of healthcare, but also on the delivery side of healthcare too. And Satya Nadella, a few years ago, who's the CEO of Microsoft, said that AI is technology's most important priority and healthcare its most urgent application. I think the context for this is really some of the supply and demand challenges that we have globally. So we have an increasing aging population with increasing complex comorbidities, and we have a massive workforce crisis in most parts of the world. The World Health Organization pre-pandemic estimated that the world will have 14 million less doctors, nurses, and pharmacists on the planet than what society would need. I would argue post-pandemic we're closer to about 25 million less doctors, nurses, and pharmacists by 2030 than what society will need. So within 6 years, we have a massive challenge around who will be delivering care for this aging population with complex comorbid needs. I teach at a range of institutions, so in the Boston ecosystem and the West Coast as well. And this kind of role of technology, if you kind of take this graph on the left-hand side, and I apologize for the font size being very tiny, just shows the rise of technology across all industries over time. And on the right-hand side, something that Vivian was referencing around the size of models that now exist and the scale that exists to inform these models. So thinking about data, compute power, and the parameters. And many of you would have heard of GPT or other similar models, and we'll talk a little bit about what they might mean in a moment. But what's really interesting is how they're now democratized. Everybody has access to them. Many of you in this room have raised your hand, may have played with them to say, write me a poem, or help me make a travel itinerary. And it's almost quite magical when you start looking at these and you start to interact with these tools in novel ways. But what we're seeing is language understanding, reading comprehension, image recognition, speech recognition, handwriting recognition surpassing human performance now around kind of the 2020 mark. And it's probably best if we demonstrate this through a series of some examples. So if you were to go to Copilot today and type in something like this, so what is metformin? Many of you will probably know what metformin is, but the response it will give you is this. And it will tell you that metformin is a prescription medication to treat type 2 diabetes and provide you some additional data. If you carry on the conversation underneath to say, can anyone with type 2 diabetes take it? It'll start to tell you about who can and who can't take it. So again, this is just something that's freely available today. Any citizen in the UK, in the US, or otherwise can begin to play with these things. So it's actually getting quite complicated in terms of the information it's providing. If you carry on the conversation even further to say, well, actually, are there alternatives to metformin? Because actually, I'm one of those people that have liver disease or kidney disease. It'll give you even more information around what the possible alternatives might be for you. And many people in this room who treat patients with diabetes will probably understand that actually that's relatively reasonable in terms of what it's providing. But all of that can be massively complicated. And you might say, actually, well, that seems massively complicated. I just don't understand what to do. And not only will it try and empathize with you, but it will recognize that you feel overwhelmed in your language. It will recognize that you feel overwhelmed and then ask you to think about a holistic way and ensure that you engage with your holistic healthcare professional team in tailoring the need to you. So it's safety nets, if you will. It will reason behind your words as you carry on the conversation. Out of curiosity, because many of you are kind of on the policy side, what's the average health literacy, the average health reading age within the US or the UK? Give me a number. Shout as loud as you can. 6th grade. 6th grade. So how old is that? 12. When you think about your medical communication, how much of it is targeted to a 12-year-old? It's an interesting question, right? And I ask that because actually the first time I ever played with this was when my 12-year-old came home with the geography homework about 22 months ago. So I had early access to some of these tools. And his homework was write a 500-word essay on the microclimate of the school, comparing the field, the playground, and the car park of the school in London. And being the heroic father that I am, I could have chosen to go to search engine of choice, type in microclimate, then understand actually is a microclimate different for grass versus mud versus tarmac. Being very lazy, I wrote down my prompt, which was write me a 500-word essay on the microclimate of a school in northwest London, breaking it down into introduction, methodology, conclusion, but put it in the voice of a 12-year-old. And when it put it in the voice of a 12-year-old, not only could I understand it and explain it back to my son, but actually I could have a better conversation with my son. I never gave him the answer, because that would be very bad parenting. But I could explain it to him on his terms. And so what I've now done in my own clinic is to challenge myself to say, if I'm having conversations with patients about diabetes or heart failure, how do I meet them on their terms and have better conversations? And when I'm at the MHRA and we look at the risk alerts that we get for drugs, often 15 scrolls worth of information, might we be able to actually communicate that better? And these tools are fantastic at summarization and communication. Many of us who have done medical school or nursing school, we often learn through clinical vignettes. So if you take a clinical vignette like this, which is from the USMLE, talking about a 12-year-old girl with a set of symptoms and some early diagnostics, we're often given a multiple choice question. You could take this entire prompt, put it into Copilot today, and it will give you the answer. It'll tell you what the answer is, and it will rationalize to you why it is that answer as well. So it's educating, not only giving you the answer, but you can prompt it to then educate you as to why you think that answer may well be true and why it possibly can't be any of the others. But remember, that's just a clinical vignette talking about a 12-year-old girl with a set of symptoms. What if we push the model a little bit and remind ourselves that actually each of these models have not been trained on any medical knowledge. They've been trained on the digital exhaust of the internet. And they have begun to reason in the background. So the same model is passing the bar exam, passing USMLE examinations, passing MBA exams in the background, and no specialized training. Imagine if we said to it, what do you think the girl in this problem might be thinking and feeling? That requires a significant level of reasoning underneath. And these have not typically been the types of models that we would have been able to have access to in the past, but it will give you a very reasonable answer. As an AI model, I cannot directly assess a person's thoughts and feelings, but I'll make an educated guess. The 12-year-old girl in this scenario might be feeling worried and scared. She may be concerned about missing school, and it's essential for the healthcare team to address her concerns and provide reassurance. There's been some papers that have been published over the last year around the empathic response that these models are giving, arguably more empathic than some of the practitioners that practice medicine today. Let's go a little bit further even than that. So the girl's name is Meg. If you were Meg's doctor, what would you say in order to provide comfort and support? And it will give you a very, very reasonable script to go in. And certainly in the UK, and I'm conscious in the US too, we have lots of role play that takes place. And that role play can be verbal, but you could end up having chat-based role play. And if you extend this out and you play with this role play, you could ask the model to assess how well you have done versus other benchmarks. And you could say, I am training to be a doctor. Please role play the role of Meg. I will be the doctor, and let's have a conversation on it. And so you'll see how these models are very, very different to any types of technology that we've used in the past and before. And again, freely accessible and available. What I would say, and there was one little bubble in Vivian's chart, which is really, really important, is thinking about how we deploy these tools in a responsible way. So the exam question that I focus on at Microsoft is, how might we transform the practice of medicine with trusted, reliable, human-centered AI? And I say that very deliberately. It's not just about AI. In healthcare, it must be trusted, it has to be reliable, and it has to be human-centered. And there are various tests that you have to pass for trust, tests that you have to pass for reliability. And when we're building models, we think about each of these things. So on a bedrock of transparency and accountability, assessing for fairness, reliability and safety, privacy and security and inclusiveness. Most life science trials that exist on the planet are not representative of people that look like me. I'm a 6'4" South Asian guy from Northwest London. Most trials that exist for cholesterol drugs, diabetes drugs, are not for me. They're for generally 40-year-old white men. They're not designed for people like us. We already have bias in our healthcare system. I think that if we were to, have a conversation about the bias, challenge ourselves, and move that we are pushing for heterogeneity of data in the development of our models, thinking very carefully about how we deploy these, thinking about the end-user impact, and push ourselves to be much more inclusive around data, where I think organizations like Kaiser can really lead the way. How might we be better at addressing some of these things? This will not be a magic bullet, but we will get there over time. And if we can identify issues with the outputs, measure them and mitigate them, we'll be way, way better off. Many of you have seen blood test forms like this. These models are pretty smart. These models can take your blood test form and you can ask it a question and it will give you a response. Say, in simple terms, explain this pathology result to me. Saves massive amounts of time, certainly in my primary care clinic, where I have to do 42 patients a day, 10-minute appointments each. And what you'll begin to see is what we didn't do at the beginning, but we do a lot more now, is ground the answers with reference points within the internet. So each of the references you can see underneath, and you can go back and validate against them to reduce the hallucinations and confabulations that many of you may have heard of in the past. A lot of that is what's happening on the text-based space. There's research saying, how might we be able to actually begin to engage with images in a different way? So what can we do with two-dimensional and three-dimensional images? And I'm sure colleagues will talk in depth about these. but potentially having conversation with the images. If you're in an ER or in an HD or an ITU setting and you can't wait for the radiologist to give you the opinion and the review, could you figure out if there's a pneumothorax here? Could you figure out whether the tube has been placed in the right place? Can you figure out if there's a temporal dimension to the tumor and it's changing over time? And we're getting better at that. In the UK, this is Dr. Raj Jenna on the left-hand side. We engaged in a 7-year piece of research with him to think about prostate cancers and radiation oncology, radiotherapy treatment for prostate cancer. It typically takes him from 30 minutes to 3 hours to contour through every single CT scan, identify tumor versus non-tumor. So in a typical day, he could plan 6 patients worth of radiotherapy. We've applied open source AI models so that takes now 13 minutes. So 6 patients an hour can now have radiotherapy planning, which means how many more patients will now have potential access to radiotherapy planning for the future. And it's an open source model. He's now adapting that to use it for glioblastomas, head and neck cancers, lung tumors, and others. So we live in a world with massive amounts of information, increase in complexity. We also have a workforce challenge around supply and demand. I think that the doctors of the future and the nurses of the future and the pharmacists of the future, the healthcare professionals of the future that have access to these models and work with these models hand in hand may be safer practitioners than perhaps practitioners that don't use them in the future, is what I would put it to you. I have a very short video, it's like 45 seconds. Would that be okay to play? So I'm not sure if this is going to work as well, but we'll give it a go. There's a short video on the left-hand side, and I'll try and talk through if it doesn't work out as best as I want it to. Can we try? Oh, here we go. So this is the model. This is demonstrating that these models can see and hear in inverted commas. So this is a model demonstrating what you can do with a bike. So this individual is trying to say, help me change my bike seat, move it up and down a little bit. And it will give you the instructions of what you need to do just based on the image. So it recognizes the bike and it recognizes your challenge. And it says to you that if you can give me a more specific picture and give me the manual, I'll help you out even further. And you might say, is this the lever? It'll say, no, that's not the lever. That's the bolt. And it will say, help me identify what you need to do next. So you take a picture of your toolbox, your Allen keys, you take the manual, and it will identify where in the toolbox you need to go, which is the Allen key that you need to use, and what you need to do next. And it does this without any specialized training. I show this because actually these are tools that will be ubiquitous in our day-to-day lives. They are not specific to healthcare only. These tools are now democratized around us. It's as if we're living in the iPhone moment, the internet moment. And the question for us, I think, is how do we responsibly deploy these? How do we responsibly adopt these and really think about the change management that needs to take place for us to leverage these in a responsible, equitable manner for the future? Thank you very, very much.
Yes, thank you. I'm going to let you sit here, Judy.
Okay, sure. Thank you. Thank you.
Thank you so much for having me. 2 terrific sessions already, and I'm excited to continue. I will say that I also have a 12-year-old, and so I think any chat GPT output that doesn't include the use of the word bruh with at least 5 U's is definitely not doing its job and will need some fine-tuning. So that's the easy case where you can easily verify the quality of the output. What I will be talking about, I think, unfortunately, is that the pathway to the future does involve some more complexity that is really happening on the front lines of healthcare delivery organizations that are having to make the decisions of, are these tools ready for prime time, and what does prime time mean in terms of safety, effectiveness, equity, et cetera. So I think you're already seeing a theme of talking about the future really is about talking about where we are in the present. And I'm going to sort of double click down and give you a perspective from our health system. What does this actually look like on the front lines in terms of how we are approaching the challenge of where the tools are today and whether they are ready for wide-scale use in our patient population? So where we started this journey was really the need for a vision, right? What are we trying to do with these tools? We don't want to just implement technology for technology's sake. We really want to ensure that they are solving our real-world problems and doing so in ways that are trustworthy. Which again is a word that we all kind of intuitively understand, but we have to operationalize that. What does it mean to be trustworthy? And how do we develop processes that ensure that the AI does meet principles of trustworthiness? That includes some of the things that you've already heard about today in terms of longitudinal AI and impact monitoring, so I'll talk about that. And the other piece is AI at scale, that it's really easy to say we have 2,000 models implemented. What we're really trying to do is to say we don't want 2,000 AI pilots. We really want to figure out which are the tools that are most valuable and get them to enterprise scale so that they can impact our entire patient population. So we are thinking a lot about how do you start with a pilot, rapidly determine whether it's doing what it's supposed to do, and then have a plan for scaling that so it does get to the enterprise level. So those are really the two dimensions that we are emphasizing: trustworthiness and ability for the tools to get to scale. So we think a lot about this 3 horizons framework in terms of whether we are using our resources around deploying AI effectively. I really like this because I think it's intuitive to think about what is your mature business, what is your rapidly growing near-term business, and what is an emerging future business opportunity, thinking about gas-powered cars, electric-powered cars, and the future of autonomous vehicles. And the point is we need to be investing on all 3 horizons, right? We need to make gas-powered cars better, we need to make electric vehicles better, and we need to be designing for this future state. So what does this mean for us in our health system? It means that right now we are just trying to make our current fee-for-service, healthcare system better by, implementing AI for operational use cases. Again, you heard about some of them already this morning. At the same time, we're thinking about our rapidly growing business. How do we think about generative AI for augmenting clinician intelligence and really bringing together the best of human and computer intelligence as that exists today and in the near future? And at the same time, we can start to see a model for AI-driven virtual care, right? Where we can get a sense for what might happen with a given patient trajectory, start to anticipate some of the lab tests they may need and send them for lab tests before they even come and see a physician, such that that interaction is really fully optimized even before the patient touches our system for a particular issue. And again, there's probably even more opportunities for that future state that we're just still trying to get a handle on. So we are, again, trying to design strategies that will allow us to invest in AI on all 3 time horizons. It takes a team to do this work well. I don't think we have the answer. Is this the right team? Are we the right expertise? Is it the right numbers? We are really all learning this on the fly as we do it. At the heart of our operation is our Chief Health AI Officer. I think you see a growing number of health systems that have these roles, and they are the sort of data science and technical team, as well as people with expertise in different sort of domains of clinical informatics. And they oversee our governance process, our technology, and then they're really supported by people in these other roles. So my division is really the group that's being brought in to think about evaluation and impact and measures of impact. And then we have our sort of clinical systems health IT team. We have people who are really thinking on sort of that 3rd horizon in terms of like the research capabilities, doing more of the precision medicine work. And we have a newly named Chief Research Information Officer that's, again, really pushing us to that 3rd horizon, while my group, even though we do research, is a little bit more current state. And then, of course, all the IT infrastructure and security, and our Chief Data Officer that's really trying to work to ensure that we have that solid data foundation that you already heard about today. So I think a lot of what we're going to learn about how to do this work well is who is the team that needs to be at the table, how do you think about the expertise, how they work together, what are the structures and functions. Our evolution over time has really started with what is the technical infrastructure that we need to be able to rapidly deploy different types of AI models. We're an Epic shop, and so we started with Epic's cognitive computing platform and pretty quickly realized that it was not going to be sufficient to meet the needs of AI at an academic medical center. So we built basically our own platform that we call HiPAC. That allows a much broader set of data to feed into models in real time. You can again see sort of the basic architecture of it and how it integrates with Epic, but also has some unique features that again allow us to deploy and monitor our models. Where are we today? We, frankly, even though I think have been at this a while, we are not in the thousands of models deployed. If we look at sort of where we are at an enterprise level scale, we're still in the early days. And we are doing sort of a mix of models that are coming from our electronic health record vendor and a set of models that we have homegrown or self-developed, either by people within our health system or by researchers. A lot of these are really still focused on those sort of operational use cases, things like the capacity management that you heard about this morning, predicting use of blood products. So again, sort of clinically adjacent and relevant, but they're not predicting diagnoses or sort of directing patients to, to certain parts of our health system yet. We're always evaluating new models, again, mostly driven by the needs of our health system, but with some capacity for what our researchers and frontline clinical faculty are interested in. We have evaluated and turned off models that we thought were problematic. And have written about sort of that process of trying to understand enough about some of the models that were available to us for us to determine whether they met our threshold for sort of being ethical. And some of them we felt like they just weren't at our institution's ethical benchmark for sort of equity of deployment. Again, it's a longer story, and I'm happy to talk about it at lunch. And then again, a lot of models coming through our pipeline. So again, just to give you a real world sense of sort of, where we are in terms of number of models that we're able to look at. We also have now GPT integrated, a secure, fully secure version, so no data goes to GPT, so it's sort of our internal product that's integrated with HiPAC that I described before. So what that means is that if you want to use a generative AI model as part of the model that you're deploying, it's sort of fully integrated in with the full architecture that then flows down to our EHR. Right now, we mostly have GPT-4, but are anticipating adding sort of Llama, and we ideally want to move, frankly, to more open source models that we can, work with in a broader set of ways. If you look at, the breadth of applications of healthcare that we hope to touch with AI, it really is, moving from that Horizon 1 to the Horizon 2 framework. We're having a really interesting meeting in a couple of weeks about how should AI support our medical education mission, right? So should we have virtual AI coaches for all of our trainees? So that as they are going through the process of training, again, this is across a breadth of different trainee types, they can have real-time feedback on their performance. Right now, it's very labor-intensive. They tell us that they feel like the feedback is delayed and they don't get enough of it. So is AI our solution there? So again, maybe 6 months from now, we'll be able to tell you where we landed there. But again, just a fascinating breadth of conversations. So we are evaluating use cases across all these different domains. Again, we talked about AI ambient scribes. How can we triage high-risk patients? Anyway, you can see down the list. I just want to keep going to get to this last section on this issue of the day around sort of AI fairness. There was a question that came in, I saw in advance, of sort of what can happen at the state level. And I will say that a lot of our work got kicked off by an inquiry that came from our California Attorney General that asked us, how are you assessing your racial and ethnic bias in the algorithms you have deployed? And we said, well, give us a few months and we will let you know. And really what we realized is that we had to start with even what do we have deployed? At that point in time, we didn't even have a sort of centralized way to know all the different models that existed at UCSF Health. And so we had to sort of come back to centralize that function and then stand up this whole governance process. So I do think even just the inquiry can be very powerful at the state level to know that someone's looking and wants to know what you're doing before we even get into sort of how do you regulate this and all of that complexity. So as I said, we have adopted a set of trustworthy AI guidelines. We decided to adopt the HHS guidelines because we think that they really do emphasize the key dimensions. Again, so much complexity in how you operationalize this, trade-offs between different dimensions. I don't know that we've got it right, but these are the conversations we need to be having amongst health systems to understand how they're thinking about this. What we have stood up is what we call our AI governance committee. They are the final sort of gatekeeper for what models get deployed to our patients. And so I sit on that committee, a bunch of different people with different expertise, and the models, every model, whether that's a research or an operational model or an EHR vendor model, come through the same governance process. And we sit down and we basically look at the models. We start with just discovery. Like, is this model trying to solve a real problem? Have they thought about the entirety of the solution, not just the model has a high predictive value, but like, do they understand how to integrate it into workflow? If we implement it, are we sure that the interventions that will come because of it are equitable? So this whole notion that hasn't come up yet today of, patient-positive interventions, right? So if we're going to predict patient no-show, you can either double book that slot, right, which is negative for the patient, and if you have an already biased model, is going to further worsen disparities, or you could say if a patient is predicted not to show, that we will provide transportation, right, and that's a patient-positive intervention. So we're really trying from the start to make sure that we're thinking about implementation of these models holistically and sort of how humans will use them and interact with them. We then do the development and evaluation, retrospective evaluation, prospective evaluation, moving into pilot or RCT, and then the adoption and ongoing monitoring. And what's important about this is it means we're touching these models many, many different times. So this is a huge amount of work just to even take one model through this process. And so what we're trying to figure out now is how do we resource this if we want to be able to put 10, 20, hundreds of models through this process, right? It's a huge amount of investment. Anyway, lots of challenges to doing this. I think we're still learning how to do it well. It's something we're trying to do in collaboration with a broad set of partners. So if these names aren't familiar to you, I do recommend familiarizing yourself with these groups of organizations that are trying to come together and develop best practices. And as we head towards the end, I'll just say that, I keep coming back to making sure that the models are good and making sure that the humans are good at using the models. And we really have to think about those two pieces together. So yes, we have to think about algorithmic vigilance, algorithmic drift, but we also have to think about clinician vigilance. Is it really realistic to think that if a model gives a clinician bad output, that a human's going to be able to recognize that and capture it and prevent that from getting to the patient? So we're really trying to bring these two together and think about measures and methods for both algorithmic vigilance and clinician vigilance. So happy to talk more about our strategy at the break, but we'll pass it off.
Okay. Good morning, everyone. So nice segue to talk about the future, looking at capacity building, especially with clinical vigilance, a lot of pitfalls. Very tough for me because I work in 4 areas. I'm an associate professor of radiology and informatics at Emory University. And one of them is bias and fairness, which I'm very passionate about. And I'm like, well, maybe I should have talked about my work about that. Or the second one, which is capacity building. And so here are my disclosures. So 2016, this one godfather of AI said we should stop training radiologists. And this had actually an impact. A lot of students became less interested in pursuing radiology as a specialty. Thankfully, it's 2024. There's not anyone who has enough radiologists to work for them. And he actually said he's leaving Google because of these existential risks of AI. I show you this just because we have a lot of hype, even now, again, with the large language models that have an impact. They have an impact early from training. You do have to really invest a lot in making sure that the right message gets out, which is actually getting a little more difficult. But I want to show you why doing this work, again, I'm just following around the same theme, that is very, very difficult. So I hope some of you or most of you have heard of these two studies, one that shows pulse oximeters doesn't work well for dark-skinned patients, and also the temporal thermometers also don't work as well. And, some of the people who wrote this work are actually very good friends of mine. We do this health equity research using data science together. And I asked them, how has your practice changed? Nothing. They know it doesn't work. These researchers in this space, we know the problem of hidden hypoxemia, where you can send patients who really don't have enough oxygen just because of the tools you're measuring. And it's really difficult to translate to practice. And so it's that theme that I'm going to use to inform sort of like what should we be thinking about the future for us. Well, here's an example from mammography. It's an experimental test. What they did is that they had 50 mammograms, and they changed the output of some of the mammograms, and then they gave them to readers of different experience. And it turns out that when AI is correct, unfortunately, if you're colorblind, it's going to be the last bar there, but the red bar is your least inexperienced reader. So if you give a correct AI output to your inexperienced reader, you improve their performance, and you raise them up to almost the expert level. But if you give them the wrong explanation, in mammograms you can either say the patient has cancer or they really don't have cancer, and you say they have cancer, or the other way around, that they have cancer but you say they don't have cancer. And it shows that you even bias your expert performance. And this sort of one of the big future is understanding how does AI and the human, in case we are not anticipating replacement, hold hands together for an impact, remains one of the biggest challenges. And here is an example. In psychology, they're able to get through a bit for this sort of experiments where they can lie to the reader. And one of them here is just, they ran 3 experiments with an imaginary use case that is saying one patient has disease, one doesn't have disease. And what they show is that when one of the experiments always has an error, a systematic error, 40% are always incorrectly classified. And they show when you give AI assistance, the error rate goes up rather than when you just left the human work by themselves. Then the second phase, they start off, giving one group, the blue one, has an error and uses AI, and the down one doesn't. And it shows that you start off with using AI and then you don't. And those participants show that when you use AI, your error rate is high. When you stop, it goes down. And then they flip the experiment. For the people who did not use AI, they use the AI in the second phase, and they show that the errors persist. I think this study, it wasn't really saying, hey, it's pneumothorax, but to me it was very concerning because it shows that the automation bias can persist even when the AI is withdrawn. We've seen a sort of a system that has actually pulled out AI. And so to me, again, I had to still sneak in a bias slide here, but it shows that we have a very, very complex system as we start to think about what the future of deployment of these systems is going to be. You have to decide, are you going to think about how you deploy, or are you going to think about how you build? We had some comments that, we are building a fair data set. I can tell you that that's impossible. The model evaluation, or how you deploy your system across the complexities of organizations. So my talk is around capacity building. I've been involved in many, many years. The first time when Geoffrey Hinton caused a drop in the radiologist interest in AI, I went back and did a lot of outreach to try to think, how do we educate? Today, I run the AI elective at Emory University. And what I can tell you is that this field is changing so fast. Today, when I look at my computer scientists versus 2 years ago, they rarely rely on the computer scientists when it's residents, because they have Copilot that helps them even program. So domain expertise is becoming very important. And so I think one of the biggest takeaways, if I think about the future, even if I don't have a crystal ball, is to think about whose voices are in the room. And to me, that's what policy is, as someone who's just learning about how to be in this space. And if you think about epistemic harm, it's the contribution of health equities that is rooted in knowledge itself. It's formation, shape, setup, and effectiveness. And it's embedded in the knowledge and the ways in which it's created and used to exact power. And it's around who gets a seat at the table. And if you see, this is not an imaginary case about whose voices is represented. It's mainly the CEOs of the big companies. And they're very far removed, in my opinion, still from the realities of healthcare. And so we see quite optimism that we're going to change how the burnout, you're going to make sure the patients get health care better. But the person who's left behind is really where, the person who's taking care of the patient. And, and I'll show you that sometimes we think about the mental models of how we think about our world, how it should and could be, the way it is, the way it's according to data, and the way it's according to model. And now we have according to AI. And the person who's determining how this world is according to AI is very different from the person who's caring for the patient. And so some of the examples, for example, social problems can be fixed by for-profit data-driven solutions. You've had prior presentation, saying maybe we're thinking about open source. We also have to think about closed models that are open for use that encourage innovation. We see quite a lot of apps tracking how much you eat, but they don't really think about the underlying complexity of obesity or access to, to the correct food. And so we see this a lot of technology being postulated as the solution for everything. We also see this focus on efficiency. Today we want to solve doctors' burnout, but I can tell you soon it's going to be how many more patients can you treat, and squeezing and squeezing and squeezing the efficiency model. I can tell you that we have to think still about what is the value, and also thinking about that investments in technology will augment human intelligence more than investment in our fundamental pillars, for example, education, culture, and the institutions. And so it's this gap about where should we put our limited resources and how that is going to change the future. And so when I think about can we really, what have I learned in my years working in this space, it's really been around learning with others. And that's, I can try to tell you what my thought process has been. And it's this concept that we realize it's very difficult to go through school, to change curriculums, to really learn, okay, the Kaiser data, what are our pitfalls unless you have people working on those data sets. And so for a long time, we've run this data-thon, so we bring different experts to work on the data sets. And I can tell you some of the realities tend to be, I didn't realize that my recording of the arterial blood gas 5 minutes later, because it's not automatically captured, has an impact on how the data are analyzed. So it's this gap. But it turns out with the technology that is getting there, that programming can be done by high school students. We have to really rethink about how do we think about educating and localizing concepts of fairness, accountability, transparency, and thinking and moving to these HISCAMs for how do we think about this concept of discussion around policy. And this is an example of one that was done in Uganda. I can tell you as someone who does fairness work, I only knew that I'm Black when I moved here 10 years ago into the US. And so fairness has a very, very different concept based on where it's done. We know that in Europe, there's actually a penalty for social risk classification and social scoring systems. We know that in our country, there's a big debate about the woke and the not woke, and it is getting very, very tough to do this type of work. And so we have to be really intentional in terms of how we are thinking and actualizing and contextualizing what we do and think about policy. So I started off with 2016. Thankfully, I still have a job, and the giants are dropping off, but also trying to tell you what has informed, really is looking for advice. How should we be thinking about even how we fashion policy? And I want to leave you with a call for you to emphasize on learning from the past mistakes. We see a lot of technology being slapped on, for example, EMRs, which all the doctors and the nurses hate. We think about how do we empower this learning workforce and learning healthcare system if we're going to think about policy that doesn't come 10 years later. And then it's this emphasis on this rapid learning cycles. How are we, by the time a paper is published, that's almost like, 2-3 years down the line from the intervention. How do we encourage, especially learning from failures? And a regrounding, especially from the past, if you think about most of the innovation has been focused on a very small subset. If we are going to envision a future that cares for everyone, we're going to need to do a lot. And so thank you again for the invitation to be part of this presentation.
Right, a big round of applause once again for all of our panelists. Thank you so much. So I'm sort of still processing so many messages that came through, really strong and powerful, and I'm sure the rest of you are too. I think I'll start off by distilling down a lot of what you said and just asking if there's one takeaway you have for our audience as they go off and do all the important work they're doing related to implementing AI in healthcare. What would that be? I'll start, yeah.
Start with me. Thank you. Can I have two?
Yeah, you can have two.
So one is, I think about a 2x2 matrix, if you will, around risk versus complexity. And if I think about healthcare all up, I think the clinical-facing use cases that we consider are generally high-risk, high-complexity work. And like colleagues have described, like Julie and Judy were talking, there's a lot of work that needs to be done if we think about the implementation of those. But the business of healthcare may afford us the opportunity to build a muscle on low risk, low complexity kinds of work. So I wonder how much productivity we might be able to unlock if we think about the impact of these tools in the finance part of our organizations, the HR parts of our organizations, and focus on boring, mundane activities that might unlock hidden potential. So that would be one kind of axis for us to think about. I also would just encourage people to play. Think about what you need to do to build your own experiences and muscle. Don't immediately deploy them into clinical, patient-facing tools and services, but just experiment with these models and tools and see what value you can have. Don't think about it as prompt engineering, but think about the act of just posing beautiful questions and seeing what the response might be and focusing on your own curiosity.
I love that advice, and that concept is one I've heard a lot recently, really trying to focus on the lower risk, but really high impact areas. And then before, I think sometimes we're tempted to kind of dive right into that slightly higher risk area, which can be more challenging. Thank you so much. Julia?
Yeah, I think my key takeaway is that we have to do this work collaboratively, and there are many forces that push you to not be collaborative, right? In some ways, the work is so hard and complex that we can just spend all our time trying to figure out how to get it right for UCSF and really miss the important opportunities to have conversations like the one we're having today. And so I think it's to really sort of push yourself to come to these events, talk to other organizations like yours, because I think that is really where the rapid learning and the sort of avoiding common pitfalls will happen, is by doing this collaboratively. And I worry that we don't have enough structures that are forcing that to happen, and we have sort of all the pressures just to stay in the four walls of our own organizations, optimize for what we're doing locally. So that's, I think, just continue to come to these. There's a lot of different coalitions that are trying to put in place those collaborative structures. So just go to one more of those than you might otherwise, because I think that is really what the key to the future is going to be.
What great advice. I was struck hearing UCSF's journey, how similar it was to Kaiser Permanente. So it was really refreshing. Judy, how about you?
So in addition to learning, which is what I would say is my reaction to your comments, is you may not have a choice really in what's coming down. If you see sort of every week there's a new policy document or new guidance. We see now every time I go to work, when the Joint Commission is coming to visit, there's even an overhead like the Code Blue announcement that the Joint Commission is here today. And the Joint Commission is now interested in what you're doing with this. We see, for example, the AG of California is here. And I think that can get very, very overwhelming. So my thing is to not be afraid to fail and to just get started. And usually I say sometimes it just means picking a simple thing. It doesn't need to be, again, patient-facing, and just starting, because it shows you so much about your own internal organization. For example, which GPT should you deploy? Even just that simple thing, you'll find out that there's so many bureaucracies and partnerships between AWS, within Azure, within every cloud provider that's going to spend years for you to solve. So if you think about your small experiments as learning and helping you get to a pillar that is going to help you to be successful, I think ultimately you're going to be successful. And that also means looking in your own divisions to see what people are doing. Sometimes you're very blinded to what medicine is doing, and yet radiology is miles away. And that can be an easy way to just get started.
I love that. And I loved what you shared also about radiology. And I think that the lessons from radiology are really a lesson for everyone in the room who's in a profession that's been told that AI might ultimately replace them. I think radiology is now the leading medical specialty in publications within artificial intelligence. And I too was in a room many years ago and was told that everyone in the room should stand up and wave goodbye to the table of radiologists. So I always like to say, we're still here, right? Sorry about that. So such great answers. So I guess I'm gonna get a little bit trickier, and maybe I'll start with you, Judy. When you're assessing a project to implement, an AI project, how do you determine the ROI? How do you determine this is the right investment we make, whether it's a pilot that we're going to scale for Emory?
So, and this is the problem of being a researcher, because you can do so many grandiose things without and kill them without a consequence. My work has always been really to think about how AI works. Does it really bring value? So anything that I stopped moving from diagnostic models quite early in my career, although I'll tell you that I'm back there for one reason, is because I felt that and really, even the research now shows that you don't really get a lot of efficiency gains when you use AI. You save radiologists maybe an hour or two. Like it's really not worth all that investment. And so the thing that I have come to when I pick a project, I do obviously have a lot of students, so I look at the learning opportunity. But also when I think about the value for healthcare, I look at what is it going to do. And living in this gray area, which is our AI world, is something that everyone in this room has to be. And the reason for that is, for example, one of my lessons this year is that all the metrics that we use for AUCs, they're useless when it comes to a radiologist, how I use AI. And it took me a long time to come to that, because what I want to know is if I'm looking at this chest X-ray, is the AI usually right or wrong? And that's almost like a positive predictive value or a negative predictive value, which I never, ever reported, and I would never use those to buy. I want to know if I'm going to hedge and say correlate clinically, how forceful am I going to come down? And so to me, I feel that the personalized metrics are a little off. The second area, as someone who works in health equity, is that the metrics are all over the place and really don't translate to outcomes. So I love the word clinical vigilance, because if you give me a model that performs at 56% ejection fraction versus 55% ejection fraction, to me, they're kind of a little bit the same. It doesn't make sense to keep tuning and tuning, because I'm not going to change my management. And so that bridge to outcome and that bridge to personalization is how today I'm thinking about it, but that's also an evolving process over this times. I said that I'm going to come back to the predictive model. I just came back from home in Africa, and the quality of care still needs to get better. And in that place, I really should be building predictive models and more predictive models.
Great, thanks, Judy. Julia, how about you at UCSF? How do you determine whether to make an investment in a new technology or use case?
Yeah, I mean, I'll agree that we are not doing traditional ROI calculations, because I think we don't have the investment piece well-defined, and we don't have the return piece well-defined. We're still trying to figure out just what are the right metrics to assess. But I think we are starting, as has come up before, with the use cases that are in your sort of high-value, low-complexity bucket. What we call keyboard liberation, I'd say, is mostly our focus, and where we're just convinced that there is a return on investment, because we know that our clinicians want to be doing less documentation, and we've seen the performance of the tools, and I think are pretty convinced that they are good enough for scaled deployment. So I think right now it's almost more of a sense that there is an ROI there rather than a traditional calculation. And I think it'll get more and more complicated as we move into some of those sort of second and third horizon to think about what are the right metrics to assess, in particular the benefits. I think we'll get a better handle on the cost, but I think that benefit one is tricky because there's lots of different dimensions of benefit. There's also going to be risk in there. So I don't see that we're going to use sort of hard and fast ROI calculations and threshold for decision making in the near term.
Julia, could you talk a little bit more for our audience about what those tools are to really help with physician, because some of them may not be as familiar with them?
Yeah, absolutely. I mean, I'd say the two that we are focusing on, again, at this scale benchmark are ambient, basically an AI scribe. So it is something that sits in the exam room, listens to the interaction between the clinician and the patient, and then generates the draft note for the clinician to review, edit, and then that goes in. So it's still a human in the loop. It's not sort of fully autonomous. But again, we've seen just even in the last year that the tools are, I think, maturing quite quickly. I'll also note we're going to pilot 2 different tools to see which one our clinicians like better, and are partnering with another health system that's going to pilot one of the same tools and then a third tool. And our goal then is to put together the results of the 2 pilots to basically be able to do an A to B to C comparison. So again, this is where I think the collaborative work can really be valuable. The other thing we're turning on is GPT response to inbox messages. We know that our clinicians are mostly feeling crushed by the volume of patient messages that they're getting, and we don't want to turn that off. But if we can make those a little bit faster and more efficient by offering them a pre-populated draft of a response, then that, I think, is a win-win. But again, are they going to take the time to edit it? Will they catch a hallucination? These are some of the risks of turning on these models. So we're also trying to sort of validate and make sure that they are sort of clinically ready across a breadth of scenarios.
I love that. And our radiologists have been using sort of GPT-generated responses in their impressions of their radiology reports. And one of the things that we hear is just how much that cognitive burden is really decreased when they're using that generative AI for just a small part of their report. So after a long shift, they're able to, go out to the gym, drive their kids around, whereas before they would have just crashed in their bed. So I'm curious, Julia, what sort of response have physicians been giving to this technology work you've been implementing?
Yeah, I think it's exactly what you said. It's not necessarily a huge time reduction. I think you mentioned this too, but it is less cognitive work. And it is more empathetic. And, so I think our sense is that, that it is relieving some of the burden. Again, we're really early on in the journey, and, we're going to measure and monitor which clinicians are continuing to use it. You can turn it off and stop using it. So I think once it's sort of out there at scale, we'll really understand, who's finding it beneficial, who's not, and what explains that. But I think for now, there's a lot of interest in the tools. I'll just note, I'm personally very curious because some of our clinicians have started to say, well, the GPT might say, I recommend you come in for a visit, right? And then does that shift the physician's propensity to say, actually, yes, I agree. I think that patient should come in for a visit or not? I think there's going to be a lot of sort of nudges and other pieces of these. So again, it's just why when we talk about thinking about the outcomes and impact, you have to take just such a broad set of measures. So they could tell us it is, less cognitively burdensome, or it isn't saving time. And we're going to have to put this all together and say, is this the win that we want or not? And it's very complicated to kind of make that final call in terms of whether the tool is doing what we thought it would.
Wonderful. And I do think it's interesting how the areas you focused on, it's been same with KP, are the areas that have the biggest bang for the buck for our people. Because I do feel that our people, and I'm hearing that from you as well, are really our greatest resource. Wonderful. Thank you. Junaid, talk about, you're looking at it from a different angle, right? Not necessarily care delivery, but from Microsoft. How does your company determine where those investment dollars should go?
So from a health and life sciences perspective, I sit on the R&D side of Microsoft. And what we don't do is say research for hire, but we do think about actually what are the biggest problems and challenges that we could try and address. And so if I think about that exam question on how might we transform the practice of medicine with trusted, reliable, human-centered AI, you could do lots and lots of things, right? You could choose to work provider-centric. You could choose to work in drug discovery, in drug development, and across the entire continuum. And when we think about where we're going to spend our time, resource, and focus, it has to be on problems, ideally, that nobody else has solved before. So we think about the Horizon 3 category that Julia was referencing, and we think about those deep, deep problems that can have transformative impact and move the needle on an industry, but can also have real-world impact. And almost think about a public value proposition, if you will. And if we were to do this, what would be the total impact on society that aligns with the broader mission around empowering everybody to achieve more? So there's some things I could probably share, perhaps over lunch, certain things I can't talk about publicly just yet. But we get a chance to really explore with these novel tools what the art of the possible might be. We kill way more things than we actually then deploy into practice. But things like that radiotherapy planning tool, for example, there's something that could tangibly make a difference from a 3-hour interaction to a 13-minute interaction, adds both productivity, reduces the cognitive load, but also has a deep and meaningful impact on cancer potential outcomes, are the kinds of work that we like to do.
Wonderful. And I'll put it back to you. What are you most excited about as you look at this next year? What is sort of the big things we should be on the lookout for?
So can I go a bit longer than a year? Because I think in a year's time, I would hope that organizations such as yourselves, Emory, UCSF, have become a lot more confident on where these tools can really work and where actually you need more evidence to deploy them in a meaningful way. But if we kind of extend it out a little bit, people talk a lot about this notion of precision medicine. I think we live in a world where we practice medicine on a law of averages. We discussed earlier the challenges around equity, fairness, and others. Can we push ourselves to be better on that? And could we move to a future where we have more precision diagnostics, more precision therapeutics, more precision ambient intelligence that allows my practice of medicine to change and allows me to actually practice in a future that allows me to be much more precise over time and way less focused on averages. And if I had access to information, so I work in primary care, so very different to secondary care settings, but if I knew not only what's in my medical record, but I knew more details around genotype, phenotype, environment, social circumstances, if you will, I think I could really offer better care to the patients and public that I serve as a consequence of that. And I think that's the future that we might be able to enable if we make the right choices now for the future.
So you're talking about within genomics and pharma and targeted treatments?
All of the above.
Okay, great. I like that. Julia, how about you? What are you most excited about? And you can go beyond a year also.
Yeah. I mean, I feel like at the most conceptual level, I am excited for the moment when our care teams, our patients say, like, we love this technology. It is making healthcare better. I mean, I just feel like we've been talking about the promise for now like decades, and it's felt like it's continued to fall short. And I really do think that in the next few years, we're going to have that breakthrough moment where the technology is going to start working for us better. It's going to make, the whole process feel more efficient, safer, like it's really putting our people, as you said, at the center. And I just think that will be such a satisfying moment because we've been putting in so much time and effort, right? So much data has gone into these systems. It feels like, well, what are we really doing with it? Is it adding value? And I think we're going to start to see it really feel tangible, that value moment. And then we're going to get to do so much more exciting stuff because we'll have sort of won back the hearts and minds of the people. And they will then say, okay, I do love my EHR as much as I love my iPhone, right? Like that will be a huge moment. Wow. And, I'm not saying that's 1 to 2 years, but I really do feel like it's starting to feel like we're flipping towards that. And I just think that's going to be such an exciting moment. Again, a lot of hard work still to get there. I don't want to trivialize it, but since you asked what I'm excited about, it is really that moment in the sense that it is finally starting to be on the horizon.
I love that. I'm getting chills as you're talking about it because I also feel that coming. Judy, how about you? What are you most excited about?
I think two things. One is we're going to an election year, and I think we're seeing quite a lot of generative AI uses beyond healthcare. And I think they're going to serve as a big lesson to the potential and the harms of this technology. So we're going to watch what the hype cycle does. I think as of today, I saw, for example, the Meta toolkit that was done to show this is AI generated, did not work, was broken down in a few hours. And it's going to really show the complexity of working in this space, not just for healthcare, for just general business. And that's going, I think, to ground or move some general policies, for example, health AI literacy for the population, even if it's at a 6th grade level. And so I think we're going to see those societal changes, and that's going to be good to allow the hard work to continue, for example, in mission critical areas like defense and healthcare. And then personally, I'm very, very excited about the potential of using AI as a hypothesis generation. And when I think about if I had all the data at Kaiser, that's what I would do. And the reason for this is that AI has amazing abilities to pick up trends that are not very obvious to us, that will take for us years to come up with hypotheses, not just for patient care, but just our practice. I'll give you an example as someone who does radiology AI. From a chest X-ray today, I can tell you the image-based age of the patient, the race of the patient, their cardiac ICD codes, their healthcare costs, with amazing ability, and even a mark of kind of where they live when you think about the area deprivation index. And those things, if you have to hire the biggest workforce to do that underwriting for you, would be impossible. It has tremendous opportunity for harm, because you can say, I'm not going to cover this group of patients. But if imaging only, there's more to an image, and we can harness that from AI. This is, to me, much more important than ever augmenting a radiologist. And I hope that we're going to see some of these bold population-based use cases and opportunistic screening as something that I'm very excited about.
I love that. And I'm really excited about the role of AI within women's health, especially in the breast cancer screening end-to-end sort of diagnosis. So thank you so much. So I think now we'll open it up to our audience and see if we have any questions from you all. I'm sure you have several.
Well, thank you so much. This is an amazing forum. I'm so happy to be here. Amy Anderson, I'm with Oracle Health. And I just want to thank the clinicians and researchers for grounding this discussion where it should be. I spend a lot of my time within Oracle, engaging with our leaders around sort of first principles. It's about, I loved how Vivian mentioned, people caring for people, and that's really what we need to focus on. I think what I learned from this forum particularly is the importance of really looking at the delivery of care, how data can inform, and then where do we apply our priorities for AI? We hear this all the time from our customers. Where do we start, right? And I'm really passionate about looking at sort of how can we enable the standard of care and practice, which we know is evolving all the time. And I think the highlights that you have mentioned, particularly around the clinical experience, is what are those roadblocks, right? So we see with personalized medicine in particular, the increasing use of NGS, right? However, what we know from clinicians is those NGS reports are not necessarily helpful in and of themselves. So, one of the things that we're doing is working with some innovative companies that are applying, AI to those tests in order to deliver insights that are based on, evidence. So I love this. I love kind of thinking about, being practical innovators and also ensuring that we have the ethical guideposts for us. So thank you.
Thank you. So I'm not sure if there was a question, but I will just latch onto one word you said, which is roadblocks. So, and I think that I do want folks to leave here knowing that sometimes there's roadblocks, almost all the time in terms of implementing them. And I don't know if I could put that to the panelists because I think it's a great question. What are the biggest roadblocks you've seen in terms of, and obviously you're going to come at it from a different angle, but in terms of trying to get this technology out to be used?
So maybe I can answer it from some of my NHS experience, if you will, right?
Wonderful.
So implementing any change is extraordinarily difficult, right? From the simplest thing that you have to think about doing. And even if you believe it's the right thing to do all of your stakeholders believe it's the right thing to do? So we've, at the hospital that I sit on the board of, we implemented Epic pre-pandemic, massive investment, really good change management. And the change management investment actually paid massive dividends because it took the clinical workforce and the non-clinical workforce alongside. And I think where I've seen things fail is when the change management hasn't been considered. And you just say, hey, deploy this thing and you'll reap the benefits, won't you? And they haven't taken the entire multiple tribes that exist within any given healthcare system along that journey with you. But understanding that change is hard and understanding that you have to get stakeholder buy-in and understanding that you can start off with some relatively small, meaningful, impactful projects with a view to getting onto more complex things is probably the journey that I would encourage people to consider. And the NHS has multiple instances of where things have failed over time. So learn from others and experience from others too.
I love that. So change management, absolutely critical with this. Julia, how about you? What roadblocks do you see being sort of the most significant?
I mean, I frankly would say I don't think that there are true roadblocks in terms of things that are stopping us. I think what there are speed bumps, and we're trying to decide how much to slow down as we see them. So probably the hardest things are like safety and equity, right? As we look at a tool, like what is the actual performance on safety and on equity that is good enough to deploy, right? And then you have to just have really complex, nuanced conversations about like what is the current state, right? Because it may be inequitable, but as long as it's better than the current state, like, is that good enough? And so I feel like you get very quickly into sort of ethics and ethical discussions. And then I will just say on our AI governance committee, it feels like, are we really well equipped to make these decisions? You know, I'm not an ethicist. And, you know, so I just think that is where it's like how sort of slow or quickly to move is really, to me, what feels like the hardest and scariest part of these decisions, right? Because it's sort of one wrong word in a Gen AI message that goes back to a patient could really be life or death. And like, we are the final arbiter of whether that model should go forward or not. So the stakes feel very high. But yet, if there's broad value to that tool, we don't want that possibility of one thing going wrong to stop us. So I'd say it's those that are, to me, feel like the biggest challenges right now.
Thank you, Julie. Judy, how about you?
I'm going to just respond to this as opportunity. What's the opportunity today? And first of all, you should have a team and you should staff it and provide the resources that you need for it. I think we are missing the patient voice, and this is because we're trying to reinvent how to communicate results to patients. And I believe that there's quite a lot of opportunity to have early engagement. For example, if you show me that GPT will be used for a rare disease diagnosis, then you know the realities of patient privacy or anonymizing someone with a very, very rare condition is nearly impossible. Yet those are the same group of patients that can benefit a lot. We see a lot of patient advocacy groups for those patients with rare diseases, but they're completely, not at the table. And I think that if we can engage them, I think we're going to mitigate some of the risks downstream, because we will, be very forward with what worked, what failed. And I think it's just a blind spot to most of us. And then the other surprising thing for me is watching this, we've deployed 2 systems for radiology at Emory, is the human factors. And I think we underestimate what that will look like. For example, one of these is a triage algorithm. We know our outpatients are long. You don't want to be sitting on a patient with a bleed when you should have read their study early. But showing people where they missed, where they, and documenting them has a tremendous impact of even how you deploy the system. Because is this discoverable? Are you going to start to say, Judy misses a lot of these cases all the time? Maybe she's not a good radiologist when they come to review me in my annual feedback. You're going to say, who else knows? And that can have such negative consequences that some people say, we don't want you to deploy it. So the technology, I do believe, with the arms race will get better, but the human factors and the human side is really, really behind and is underestimated in the success of this technology deployment.
Thank you. I think you can see why these are all such seasoned leaders. We went from roadblocks to change management to speed bumps to opportunities. So, all right, great. And any other questions? I see a couple of hands.
Sorry, I'm trying to figure out how to turn this on. Okay, sorry about that. Neil Carpenter, Redesign Health and Tau Ventures. Let me just kind of change the level of question, if we can, for just a second. A lot of how we've been talking about this is from sort of inside the care delivery system out. So let me ask a very different question. Is if we sort of took a step back to a societal level, because this is like game-changing technology, and said, as a society, how do we need to think, what is something the healthcare system could do differently with this technology that'd be beneficial to society, which is kind of above the clinician, above a specific patient, above an administrator, above a P&L. What is maybe one thing that it could do in the next 5 to 10 years?
Well, that's a very easy question, so I'm going to turn Judy, I'll start with you, just to switch things up.
So this is society. I would say that when I flew yesterday through Atlanta Airport, one of the busiest airports in the world, I see a lot of digitization, digital ID, CLIIR, TSA pre. I think we're underestimating displacement of jobs. And I think we should be looking at what that future is going to look like. Not replacement, but there will be, I can tell you that in 5 years, when I go through TSA to boarding, that there'll be very, very minimal human contact. It's very clear that you can see that this is going to happen, but we are not thinking about how to educate today our students to live in this world where they can search online and get the answers. What are those important skills to build the next generation workforce is what I would spend my money on today.
Wonderful. Julia?
Are we getting signaled? Am I going to escape with our time's up, or should I go ahead?
You know what? I think that's the perfect place to stop. TSA, since we're all dealing with the TSA. All right, great. Well, thank you once again for all of you for being, I think, so honest, really, with the problems you're dealing with, and also being very brave and paving the way for the rest of us. So thank you. A big round of applause for our panelists. All right, great.
All right, huge thank you to Dr. MacLean and our panelists for such an interesting conversation. We are going to transition now to lunch, which is going to be served in the very back, buffet style. We encourage you to bring your lunch back to your tables, or for those of you not seated at a table, there are tables near the buffet area. And please do be back in your seat on time. We will start right at 12:30. Thank you.